This is the part 2 video on Gonioscopy from Shield's textbook of Glaucoma 6th edition, chapter 3, page number 44. Okay. So in the last video, I read about gonioscopy principles, direct gonioscopy, indirect gonioscopy, and the lenses, their principles, okay, their advantages, the comparison between direct and indirect gonioscopy, and disinfection of the gonio lenses. It is similar to the tonometers, okay. In this video, we'll see the gonioscopic appearance of the normal anterior chamber angle, and in short, what is cycloscopy, and other methods also to visualize the anterior chamber angle. Okay, so gonioscopy, it is from the Greek word gonio means angle and scopy means to view. Okay, so this is the combination of two words. Gonioscopic appearance of the normal anterior chamber, starting at the root of the iris and progressing anteriorly toward the cornea. The following structures can be identified by gonioscopy in an adult with a normal angle. Ciliary body band. Ciliary body band, it is the anterior face or anterior surface or anterior portion of the ciliary body. This portion includes the radial and circular fibers, of the ciliary body, and the longitudinal or meridional fibers are not visible because they are inserted into the scleral spur and they are obscured by the presence of the scleral spur, and posteriorly they extend into the suprachoroidal lamina, even beyond the equator. Okay. So ciliary body band. The ciliary body band is the portion of ciliary body visible in the anterior chamber as a result of the iris insertion into the ciliary body. The width of the band depends on the level of iris insertion and tends to be wider in myopic eyes. In myopic eyes, the anterior chamber is deeper, okay, and narrower in hyperopic eyes, and narrow anterior chamber in hypermetropic eyes. The color of the band is usually gray or dark brown. Scleral spur. This is the posterior lip of the scleral sulcus, which is attached to the ciliary body posteriorly and the corneoscleral meshwork anteriorly. It is usually seen as a prominent white line between the ciliary body band and functional trabecular meshwork, unless it is obscured by dense uveal meshwork or excessive pigment dispersion. Variable numbers of fine pigmented strands may frequently be seen crossing the scleral spur from the iris root to the functional meshwork. These are referred to as iris processes and represent thickening of the posterior uveal meshwork. Now once again, the scleral spur. This is the posterior lip of the scleral sulcus. What is scleral sulcus? It is the groove, okay? It is the groove on the inner surface of the limbus, scleral sulcus, and its posterior projection on the inner surface, inner side, is the scleral spur. And to the scleral spur, what is attached? The longitudinal muscle fibers of the ciliary body. The scleral spur, it is nothing but the prominent projecting part that is present on the inner aspect of the scleral sulcus. Now what is scleral sulcus? It is the groove. It extends from the scleral spur to the shawl base line, and it is present on the inner surface of the limbus. The groove that is present on the inner surface or inner portion of the limbus is the scleral sulcus. This is scleral sulcus, and its posterior projecting part is called as scleral spur. Now, what is attached to the scleral spur? Posteriorly, ciliary body muscles, longitudinal muscles are attached, and anteriorly, scleral spur, corneoscleral meshwork is attached. And it is seen as a prominent white line between the ciliary body band and the functional trabecular meshwork. Functional trabecular meshwork. This is seen as pigmented band just anterior to the scleral spur. Although the trabecular meshwork actually extends from the iris root to shawl base line, it may be considered in two portions: the anterior part between the shawl base line and anterior edge of the Schlemm canal, which is involved to a lesser degree in aqueous outflow. B. The posterior or functional part, which is the remainder of the meshwork and is the primary site of aqueous outflow, especially that portion immediately adjacent to the Schlemm's canal. The appearance of functional meshwork varies considerably depending on the amount and distribution of pigment deposition. The tubercular meshwork has no pigment at birth, but with age, color develops from faint tan to dark brown, depending on the degree of pigment dispersion in the anterior chamber. The distribution of pigment may be homogeneous for 360 degrees in some eyes and irregular in others. In the functional portion of the meshwork, especially when lightly pigmented blood reflux in the Schlemm canal may sometimes be seen as a red band. So, tubercular meshwork, it is divided into two parts, anterior and posterior. Posterior tubercular meshwork is pigmented one, and anteriorly it is lightly pigmented, okay? And the anterior part, it extends from the shawl base line and anterior edge of the Schlemm's canal, and posterior from the anterior edge of the Schlemm's canal to the scleral spur. The appearance of even the ciliary body, okay. I should stop saying okay, it's like irritating when I hear myself while editing the video. When I say okay, it irritates myself, so I should stop saying okay, it's very irritating. The appearance of the functional meshwork varies considerably depending on the amount of distribution of the pigment deposition. So at birth, the tubercular meshwork is not pigmented. The tubercular meshwork has no pigmentation at birth, but with age the color develops from faint tan to dark brown, depending on the degree of pigment dispersion in the anterior chamber. The distribution of pigment may be homogeneous for 360 degrees in some eyes and irregular in others. In the functional portion of the meshwork, especially when lightly pigmented blood reflux in the Schlemm's canal may sometimes be seen as a red band. When the red band is seen in the functional portion, that is the pigmented portion of the tubercular meshwork, it is suggestive of the Schlemm's canal, and usually it becomes prominent when there is a trauma or when there is increased episteal venous pressure. In case of the Sturge-Weber syndrome, when there is increased episteal venous pressure. So that was all about the tubercular meshwork. I am repeating it because it's very small. Only 2 pages are there. Okay? Not even 2 pages. 1.5 page only. So I can repeat the things. Okay, it is heavily pigmented in pseudo-exfoliation glaucoma and pigment dispersion, homogeneous appearance in pigment dispersion syndrome, and it is patchy, blotchy appearance and irregularly dark pigmentation of the tubercular meshwork. It's seen in the pseudo-exfoliation syndrome, along with the other findings of the pseudo-exfoliation syndrome. Shawl base line. The shawl base line is the junction between the antechamber angle structures and the cornea. It's a fine ridge just anterior to the meshwork and is often identified by a small buildup of the pigment, especially inferiorly, by using a thin slit beam at slightly oblique angle. This line can be identified by the corneal wedge created by light wedge created at the junction between the inner light beam along the corneal endothelium and the outer light beam along the corneal scleral junction. I have a very beautiful video how to identify the shawl base line. I'm gonna add this at the end of this video, how to identify the shawl base line by corneal wedge method, okay, by creating a corneal wedge using the slit lamp, and how to do that, and how to identify the shawl base line, and why it is significant to locate the shawl base line and to confirm the location of the shawl base line, why it is important. That also that ophthalmologist has explained very nicely with the example. So you should see that video for sure at the end of this video for your own understanding. Normal blood vessels. Blood vessels are normally not seen in the angle, although loops from the major arterial circle may appear in front of the ciliary body band and less commonly over the scleral spur and tubercular meshwork. These vessels typically take a circumferential route in the angle. Okay, normally the blood vessels are not seen, but when they are seen, Then we have to distinguish between the neovascularization of the angle and the normal vessels. The normal vessels are what? Normal vessels are circumferential, okay? These are regular and circumferential. Actually, after completion of the gonioscopy, first I'll read it from the shields. Today I'll complete the gonioscopy from the shields glaucoma, and then tomorrow I'll talk about the gonioscopy. Tomorrow I'll read gonioscopy from the Jacobi's, and the day after tomorrow, for 3-4 days, it will take to read it from the Irvings because it's given nicely in a very explained and elaborate way. They have like discussed gonioscopy very nicely there. With all the classification, everything is combined there. But I would like to contribute in my own way at the end of all these parts that I read from the Jacobi Shields and from Irving's. I'll add some pictures and videos from different conditions, how the angle is seen in different conditions that I'll combine from the internet, and I'll make it available for you. And I think and it is also nicely given on the gonioscopy.org site. That also you should see, it's very nicely given. I have not gone through everything, but I saw the headings and first video I liked it so much, so that also you can refer, and I'll see if anything is missing there. I'll combine it all for you and for my own self. Blood vessels are normally not seen in the angle, although loops from the major arterial circle may appear in front of the ciliary body band and less commonly over the scleral spur and trabecular meshwork. They are present on the anterior surface of the ciliary body band, and they rarely extend over or cross the scleral spur and extend onto the trabecular meshwork. Rarely they do. Normal vessels. And these vessels typically take a circumferential route in the angle. In addition, an anterior ciliary artery may occasionally be seen as a more radially oriented vessel in the ciliary body band of lightly pigmented eyes. So usually circumferential, and radially oriented you can see anterior ciliary artery, which is seen occasionally in the ciliary body band, that is seen in the lightly pigmented eyes. Circumferential and radial vessels may also occasionally be seen in the peripheral iris of lightly colored eyes. Again, lightly colored eyes, peripheral iris, you can see these circumferential and radial vessels. Radial vessel is the anticiliary artery because it comes like this. Okay. In a study of 100 patients with abnormal antechamber angle vascularization of unknown cause, 60 patients had normal angle vessels in both eyes and 10 patients had normal angle vessels in one eye. Radial vessels were more common in the peripheral iris, whereas the circumferential type was more common on the ciliary body band. So, they studied 100 patients with abnormal antechamber angle vascularization of unknown cause. Out of these 16 patients had normal angle vessels in both the eyes. 10 patients had normal angle vessels in one eye. So 26 out of 100 patients, 26 patients had the normal vessels, out of which 16 had in the both eyes and 10 having in the one eye. Radial vessels were more common in peripheral iris, whereas the circumferential type was more common on the ciliary body band. So circumferential type vessels are more common on the ciliary body band, and radial are more commonly seen on the iris, because obviously iris is like this, so radial, and ciliary body is like this, so circumferential. So it's very easy to understand that. Recording gonioscopic findings, various classification systems have been suggested for describing the width and appearance of the antechamber angle. However, descriptive words and drawings are probably the most useful technique for recording gonioscopic findings. The recorded data should include a configuration of the angle, depth of the angle on the basis of the most posterior structure that can be seen, degree of pigmentation, and presence of abnormal structures. Once again, the recorded data should include a Configuration of the angle. B. Depth of the angle on the basis of the most posterior structure that can be seen. C. Degree of pigmentation, and D. C. Degree of pigmentation, and D. Presence of abnormal structures. For example, a normal angle might be recorded as wide open with visualization to a wide ciliary body band for 360 degrees and moderate trabecular measure of pigmentation. Drawings can also be placed on a chart with concentric circles to document more specific details. Cycloscopy. This technique allows direct visualization of ciliary processes under spatial circumstances such as the presence of an iridectomy, wide iris retraction, and iridia, and in some patients with aphakia. The main value of the technique is in conjunction with laser therapy to the ciliary processes, transpupillary cyclophotocoagulation discussed in section 3 that I'll discuss later on at the end of the gonioscopy, laser trabeculoplasty, then laser goniotomy, and cyclophotocoagulation, laser cyclophotocoagulation that I'll discuss later after gonioscopy. So cycloscopy is the visualization of the ciliary processes, direct visualization of the ciliary processes at a spatial circumference. Obviously we cannot see them because of the iris, okay, at root of the iris and iris we cannot see the ciliary processes. So in conditions like iridectomy, wide iris retraction, aphakia and iridia, we can see these ciliary processes, and their value is in conjunction with the laser therapy to the ciliary processes like in cyclophotoablation or cyclophotocoagulation. Transpupillary cyclophotocoagulation. High resolution ultrasound biomicroscopy. Another useful clinical tool to examine the anterior ocular segment is ultrasound technology. Ultrasound echoes are produced from interfaces of fluids and tissues. The differences between fluid or tissue properties yield certain echo characteristics between the interface of various compartments or tissue densities. The echo is optimal when the acoustic wave is oriented perpendicular to the interface. Ultrasonographic techniques can provide information in the amplitude mode or A scan or in brightness mode or B scan. A scan means amplitude mode, B scan, B stands for brightness mode. Okay, I should not say okay. In general, low frequency ultrasonography allows deeper tissue penetration, low frequency, deeper tissue penetration but lower resolution, compared with high frequency provides higher resolution but shallower penetration. There is a wide range of frequencies currently in use of ophthalmology. So low frequency means low resolution and high penetration, and higher frequency means shallow penetration, less penetration and more resolution. There is a wide range of frequencies currently in use in ophthalmology from 10 MHz to image the globe and orbit to 20 MHz, which images from the cornea to the posterior lens, 35 to 50 MHz, which image from the cornea to the anterior lens, and 100 MHz for imaging the cornea only. Frequencies 20 to 50 MHz, which are used to image the anterior segment, are referred to as high-resolution ultrasound biomicroscopy. Frequencies of 20 to 50 MHz, which are used to image the anterior segment, are referred to as high-frequency or high-resolution ultrasound biomicroscopy. So 10, 20 and 30 to 50. 10 for the entire globe and the orbit, 20 till from cornea to the posterior lens, and then 35 to 50 from cornea to the anterior lens. So between 20 to 50 it is called as high resolution ultrasound biomicroscopy for the anterior ocular structure visualization. High resolution ultrasound biomicroscopy allows for non-invasive means of visualizing anterior ocular structures at high resolution. In the management of patients with glaucoma, high resolution ultrasound biomicroscopy is helpful to define the anterior chamber angle anatomy when it cannot be seen gonioscopically, as well as structure and relationships among the iris, ciliary body, crystalline lens, intraocular lens, and anterior vitreous. For example, when the cornea is cloudy in shallow anterior chamber, okay, it's taking time, you can see the anterior chamber angle in that condition using the ultrasound biomicroscopy. Even optical coherence tomography. Now, what is optical coherence tomography of the anterior segment? In short, it's given here in this paragraph. Optical coherence tomography of the anterior segment introduced in 2006 recently. My second year of MBBS. Introduced in 2006, anterior segment optical coherence topography or anterior segment OCT provides a non-contact, non-invasive means to image the anterior chamber angle anatomy. The anterior segment OCT uses a 1310 nanometer wavelength compared with the 820 nanometer wavelength for posterior segment imaging. The anterior segment OCT has high resolution compared with high resolution ultrasound biomicroscopy for imaging structures in the iris and the angle anatomy. The anterior segment OCT is limited to imaging the cornea, anterior chamber, angle anatomy, and central portion of the lens to the pupil. This instrument is unable to adequately image the anatomy of the ciliary body or tissue masses behind the iris. So they are using what? They are using the light waves, using the wavelength of light wave 1310 nanometer. Now 1310 nanometer means it is a light wave, electromagnetic wave that is not visible. Compared with 820 nanometer wavelength for posterior, so it is infrared wavelength. So anti-segment OCT 1310 nanometer infrared range compared with the 820 nanometer wavelength for the posterior segment. So OCT can be used to see the anti-segment and posterior segment. Anti-segment they use the, in both the cases it's infrared that we cannot see, infrared electromagnetic wave. For anterior segment it is 1310 nanometer. For the posterior segment it is for posterior segment it is 820 nanometer wavelength. Means longer the wavelength. Actually usually how it is, longer the wavelength better the penetration. But here it is like 1310 anterior segment and 820 posterior segment. Okay. The anterior segment OCT has high resolution compared with high resolution ultrasound biomicroscopy. When we compare the anterior segment OCT with the ultrasound biomicroscopy, the anterior segment OCT has a high resolution. The structures are more clearer on the anterior segment OCT than the ultrasound biomicroscopy. For imaging structures in the iris and the angle anatomy, the anterior segment OCT is limited to imaging the cornea, anterior chamber, angle anatomy, and central portion of the lens. Cornea, anterior chamber, angle anatomy, and central portion of the lens to the pupil. This instrument is unable to adequately image the anatomy of the ciliary body or tissue masses behind the iris. Okay. So it's not the most peripheral. It is not capturing the most peripheral structures like ciliary body and the root of the iris and the tumors behind the ciliary body or the root of the iris. We can see only cornea, then anterior chamber angle, and central portion of the lens with the anterior segment OCT. But ultrasound biomicroscopy between 20 to 50 megahertz, it will give us the details of the ciliary body, the tumors behind the root of the iris, and the ciliary body details, ciliary body pathology. In that sense, the ultrasound biomicroscopy has more advantages over the anterior segment, but anterior segment OCT has a better resolution than the ultrasound biomicroscopy. Now figures. Figure 3.5, normal adult anterior chamber angle showing gonioscopic appearance right and cross section of corresponding structures left. 1 ciliary body band, 2 scleral spur, 3 trabecular meshwork, degree of pigmentation varies, 4 Chauvet line. Now ciliary body band, it is made up of the antiface of the ciliary body between the scleral spur and the root of the iris, made up of the which structures, which muscles, oblique and radial, not the longitudinal. Longitudinal or meridional fibers. Longitudinal means meridional. Meridional means longest axis of the longest diameter. So meridional fibers are obscured by the scleral spur. Now scleral spur is seen as a prominent white line. It is nothing but the projecting part of the scleral sulcus. Okay, scleral sulcus is nothing but the groove on the inner surface of the limbus, extending from the Chauvet line or descemet membrane ending to the scleral spur here. Then it is seen as a prominent white line. Now trabecular meshwork, it is divided into two parts, anterior and posterior. It is the pigmented part. Posterior one is the most pigmented part. Anterior part extends from the Chauvet line to the anterior edge of the Schlemm's canal, and beyond that, from the anterior edge of the Schlemm's canal to the ciliary body, it is the trabecular meshwork functional part, that is the more pigmented part. So actually, trabecular meshwork extends from the iris root, not even ciliary body, it extends from the Schwalbe's line to the iris root. That you remember. Now Schwalbe line is again the white line, but how to differentiate between the scleral spur and Schwalbe line, and how to see when it is a closed angle, especially in children. Okay, so in children actually we use the direct gonioscopy. Okay, so corneal wedge is not possible with the direct gonioscopy. I don't think it is possible. I have not witnessed direct gonioscopy, but as long as they have described that we cannot adjust the illumination with handheld focal illuminator, I don't think corneal wedge identification is possible. So in angle closure cases, it is usually very important to identify the Schwalbe's line. Okay, for the grading of the angle. I should not say okay again. Schwalbe's line. So it is present at the end of the decimus membrane. It's a prominent line, and when it's very prominent, it is called as posterior embryotox. So it is seen in exenful and Rieger's anomalies, exenful Rieger's syndromes that we have already discussed. You can see that exenful Rieger syndrome part. I mean that glaucoma videos, I started from that video only, exenful Rieger syndrome. So there you can see what is posterior embryotoxon and how it is seen. But later in childhood glaucomas, when I'm going to read after completing 2-3 basic chapters from Shields, after reading basic chapters like tonometry, gonioscopy, assessment of the visual field, and optic head appearance, first 4 basic chapters I'll cover from Shields and other standard books. Then I'll talk about the childhood glaucoma also. In that, I'll talk about exenful Rieger syndrome once again with the pictures, more pictures. In previous videos, I think I have not added pictures. Many pictures I have not added. So figure 3.6. And one more thing I missed, the trabecular meshwork. Sometimes red band or red line is seen in the region of the trabecular meshwork, and it is Schlemm's canal. Okay, blood reflux in the Schlemm's canal that is seen in the traumatic cases or increased episcleral venous pressure cases, for example, Sturge-Weber syndrome. Now figure 3.6a, figure A from 3.6. Going from iris eye to the cornea, C, the structures normally seen by gonioscopy in the open adult anterior chamber angle are the ciliary body band, scleral spur, and the functional portion of the trabecular meshwork TM. Then B, figure B. In this eye, the ciliary body band is light grey. Trabecular meshwork is heavily pigmented. The thinner pigmented line above the meshwork arrow is Schwalbe's line, more easily seen in some eyes because of pigment built up along the bridge, especially in the inferior quadrants. So the pigmented line that is anterior to the Schwalbe's line is called as Saint-Paul's line. It is seen in the pseudoexfoliation syndrome in case of the trauma also, especially in the pseudoexfoliation syndrome and pigment dispersion glaucoma. Now figure C. Whereas the ciliary body band may appear dark brown in some eyes, for example A above, it may be a slate grey band in others as seen in this image just above the iris root. Also note the numerous iris processes which typically extend across the ciliary body band and scleral spur to the trabecular meshwork, which is medium brown in this image. D. Sometimes helpful in identifying the location of a lightly pigmented trabecular meshwork is a blood reflux in the Schlemm's canal. They have shown blood reflux in the Schlemm's canal in figure T. You can see the red line. Figure 3.7, schematic representation of penetration of acoustic sound waves by different ultrasound frequencies, modified with permission from Cynthia Kentucky. So you can see 10 MHz low frequency, 10 MHz better penetration but less resolution for the imaging of the globe and the orbit. then 20 megahertz up to the posterior capsule of the lens, and then between the 35 or 30 to 50 megahertz from the cornea to the anterior surface of the lens. So that was all about the gonioscopy in short from Shields' textbook of glaucoma. I conclude there are other 2 points: aqueous humor dynamics, fluorophotometry, and measurement of the episkeletal menstruation and tonography. That I'll talk in short, I'll read in short after I finish the gonioscopy from Arvind also. So right now I'm not gonna discuss about that thing. So at this end of the video, I'm gonna post corneal wedge, how to identify the Schwalbe's line, making the corneal wedge. Okay. At the end of this video, I'm gonna post a very nice video from a very good ophthalmologist who is specialized in glaucoma and cornea. Okay, his super specialty is in the glaucoma and cornea, and he's a very I like his videos. I have seen his gonioscopy videos; they're excellent, and therefore exercises also you can. I'll just share the link also in the description box, and yeah, you see how to identify the Schwalbe's line using the corneal wedge. And in the next video, I'll talk about the gonioscopy from Jacobi. In the Jacobi, they have not described the grading of the classification of anterior chamber angle. That we'll see in, that is the sheet classification, Schaffer classification, then Spade classification, modified Foster classification of anterior chamber angle. Then after that, anterior chamber angle, Van Herrick's technique to grade the depth of the anterior chamber angle. That also, and the technique to, the standard technique to assess the depth of the anterior chamber angle at the periphery. That video and grading also I'll talk at the end of the gonioscopy series. That will be after reading the Arvind's only. So be patient. If you want to see the gradings and all, you can just follow up the series of the glaucoma if you're interested. So that was all about it. And reading the textbook, because after whenever I watch the videos, everything is covered, but some things are missed. And even in one book, everything is not given. So I'm combining all the standard books and the pictures and videos I like on the YouTube and on the internet. And I'm reading the books because no video on the internet can substitute the standard textbook. So I'm reading the standard textbook, and there are no audiobooks on YouTube of standard ophthalmology books. So it gave me an idea that let us make audiobooks. Means I don't have the memory in my cells, so I'm sharing it here because their text charge is like 650 rupees per month, and I need like 1 TB, 2 TB memory to store my all videos. So I decided to use YouTube channel, whether anyone is gonna see or not, I don't care honestly. But if people are seeing and getting benefited, it's good. But I myself am getting benefited because sometimes my eyes, they burn. Even if I read a book, I get very tired and I get sleepy. So when I hear something, even if I'm sleepy, when I hear something, I remember it well because I have already read it and I have already seen the pictures. So if I hear these things, it helps me to revise the things nicely when I'm tired, otherwise I can read. So that gave me an idea to make audiobooks. But my accent and my pronunciations are not so correct, so I'm working on that also to sound better and nicer and softer. So for that also I'm practicing. I'm referring some good YouTube videos to improve my accent and pronunciations. So thank you so much for listening to me patiently. Bye.
This is the first video in this series of Science in Glaucoma. Schwalbe's line is the starting landmark when doing gonioscopy. In this photo of a model, this is the location of the Schwalbe's line. Behind it, you have the trabecular meshwork, than the scleral sphere. Here you have the ciliary recess and iris. We all know that aqueous passes through the trabecular meshwork to reach to the canal Schlemm. So you need to start by identifying the Schwalb's line so you can see whether the trabecular meshwork is visible or not. So this is the starting point. Here, this is the cornea. Section in a cornea on a slit lamp, you're going to see inner and outer surface and in between translucent tissue. On the other hand, back here in the area of the trabecular meshwork and the scleral zone, you're going to see only inner surface. This is the location of the Schwalb's line between the cornea with inner and outer surface and translucent in between, and sclera, which is opaque. This is the extent of the Schwalb's line. Actually, this model is not accurate. It should be like that. We all know that the cornea wedge is inserted into the opaque sclera. So in reality, you are going to see this area translucent, this area opaque. If you follow to the inner surface, this is the location of the Schwalb's line. I put the model on a slit lamp. You can see in the upper part section in the cornea with inner and outer surface, while in the lower part only inner surface. This is the trabecular meshwork. It's opaque. And this is the location of the Schwalb's line. This is the starting point. In a patient, this is the way it's going to look. This is the wedge shape of the cornea. If you follow this wedge, this is the location of the Schwalb's line. You have to identify it by a section. This point here, where there is translucent in between anteriorly and opaque posteriorly. Once you see this, you can identify the rest of angle structures. Thank you for your attention.
This is a brief clip showing the corneal wedge in a patient whose angle is almost completely closed. Notice that the anterior and posterior beams come together at the iris insertion.
The corneal wedge described by Posner and Gorin in 1967 is formed by the sharp transition of clear cornea to opaque sclera, with the tip of the wedge indicating the level of Schwalbe's line. It is easiest to learn in a wide open angle where you understand the anatomy already. One uses a slit beam angled in at about 20 degrees, a high intensity light, and narrowing the beam, one can identify the corneal wedge and the level of Schwalbe's line. The technique is not easy to learn, but once mastered will become very useful in identifying questionable angles. You might wonder whether this is an open angle with no trabecular pigmentation or synechial closure. One uses the corneal wedge to answer the question. High intensity light, and the wedge indicates the level of Schwalbe's line. The angle is wide open. In this next case, the view is hazy because of corneal edema, raised intraocular pressure, and we use the wedge technique to find the level of Schwalbe's line. High intensity light, a narrow beam, and the wedge indicates there's definite synechial closure.